We are so blessed to have both of you as the first guest on our telethon. You both are cutting the edge in the stroke world. I love both of you because you never say no. You're open to different things and you're really on the cutting edge. And Dr. Bekelis, people trust you so much, and your voice, that you're heard. And that really is, and for us to have you or to welcome you as a guest is really a gift for both of you. We love both of you. So thank you so much for joining us today and for beginning our telethon in this way. And I know you have lots of visits to make and all that, and I know we only have till 10 o'clock, but we really wanted to welcome both of you. So thank you so much for joining us today.
Thank you, Renee, for having us and for all you do for stroke through this event, but whatever you do through your regular show and everything else.
Thank you.
What's happening right now in our center is that we're integrating artificial intelligence into the quicker diagnosis of strokes, and it's actually the first of its kind on Long Island. So we have the ability to recognize large vessel occlusion or a large blockage in the blood vessel in the brain much faster than before, by harnessing the power of artificial intelligence. So we're using a system called Rapid AI, which is an AI system, and that picks up the stroke, obviously, if somebody's having it in the hospital or outside and they're in the emergency room, and can notify the team. So you're cutting through barriers of time, you're taking away the human factor in recognition of an image, and you're able to provide care a lot faster. And as you know, all of you know, because you're intimately involved with stroke or have had personal experiences with stroke, time is of the essence when it comes to stroke. So the faster you're able to intervene, the better the outcomes are going to be. And so it's very challenging for us to cut down on those times, because obviously there's a lot of components. Stroke is one of those diseases where you have multiple different moving parts that it's at times very hard to align. Somebody shows up in the emergency room, they have to get recognized, get imaging, see multiple doctors, get potentially clot busting medicine like the TPA, and then possibly get a procedure through the groin to open the blood vessel in the brain, what we call mechanical thrombectomy. So an array of things that need to happen, but really if you integrate these artificial intelligence components, you can cut down on those times, remove how many people need to be involved to get to a decision. And that's how you can really streamline stroke care. For example, yesterday we did mechanical thrombectomy or the stroke surgery in 3 patients, one after the other, and we were able to do that because of this new system that allows us to quickly transition from one patient to the next and go through images fast and identify the problem. And I think it's tremendous because now there's no delays, and again that's to the benefit of the patient. So I think this is one of the most exciting things that we're currently doing in the stroke world to try and cut down on times. A lot of new things are happening also in terms of the medications we're giving. We know, for example, that for the longest time, TPA or the clot busting medicine, alteplase, is the standard of care before you need a mechanical thrombectomy, if you need a mechanical thrombectomy, if you need the surgery. But the majority of the strokes, the small kind of strokes, will benefit from the clot busting medicine. They're not going to benefit from the surgery. And so it's very important to give that medication. Now, we're finding that there's other similar medications, similar clot busting medicines that can have a better, potentially better result when it comes to opening the blood vessels. So, for example, tenecteplase is one of those. And so we're in the process of integrating that medication in the stroke treatment protocols. Other developments have to do with, again, advanced identification of stroke. So, when somebody wakes up with a stroke, right, and you don't know when the symptom onset was, in the past, you couldn't offer treatment. Now, when it comes to the most severe strokes, we have the ability still to offer treatment using advanced imaging, what we call CT perfusion, to identify whether the brain is alive or not, regardless of when the stroke started, and within a 24-hour window, and still go through the groin and pull those clots out mechanically. Now we're adding another component to that by using MRI technology for wake-up strokes that are not as severe, but still could be debilitating, right? And so we're using MRI technology to identify which strokes are viable, and then something which was unheard of before, now administer clot busting medicine without knowing the time of onset, just based on MRI technology and images. So really, the stroke field is moving forward very, very aggressively, and we're very excited to be part of that. And obviously, we're very excited to partner with folks like you that spread the word out to get the patients to the hospital, because all the nice stuff that I'm mentioning are on the back end. What happens in the front end is really key. Identifying that you're having a stroke or that your loved one is having a stroke and getting to the hospital is 90% of the battle. The quicker you get to the hospital, the quicker you will recover. And so your guys' mission is really what keeps us going. Without what you do, a comprehensive stroke center like the Stroke and Brain Aneurysm Center on Long Island, like our center, would not be able to perform and to help patients. And so, the front end, and you're saying, that we never say no. We never say no because your mission is actually more important than ours. On the back end, I used to say, we're glorified plumbers. We'll open the blood vessel, no problem. But getting the patient to the right place at the right time is really what makes the difference. And thank you for that.
Wow. Our pleasure. And we do it because, of course, we've experienced it and we know what it feels like to have a stroke or to have a loved one have a stroke. Alicia just suffered a TIA recently. And the only reason she knew that she could possibly be suffering a stroke or TIA was because she's a part of our foundation and she knew the signs. And Alicia, you went right to the hospital, right?
I did. I went right away. I knew it. When I told my husband, he just said, no, it's not that. But I knew that it was, and I'm so glad that I went through it. And thank God that it was because of your show and the knowledge that I've gotten from your shows.
Wow. Thank you. And and if we could save one life, that really is our goal. One life, and the other thing is that one of the things that we always promote is if you could be suffering a stroke, when you call 911, to be sure to let the ambulance know, because then they'll go into stroke mode. They'll know what to look for when they get there, and then when they call the hospital, they'll prepare and you'll go past triage. You won't have to wait. So it really is a key. Like, that's one of the things we added on to I know it's BFAST now, right, Dr. Bekelis? It's BFAST.
Correct. Yeah, it's balance, vision for eye, face, arm, speech, time to call 911. And what I usually say is, if you have any concern, you think you're having a stroke, even if it's not the classic symptoms, right? Go to the hospital, call 911, go to the hospital. The risk of really having a stroke and not being there on time is a lot higher than just going to the hospital and them saying, you know what, it wasn't a stroke, it was X, Y, or Z, you're fine to go home. And another important thing, during the pandemic was that we, across the world, we would see this, what folks in the UK called the vanishing stroke phenomenon. And that was obviously just a way of saying that folks were afraid to go to the emergency room. Regardless of what's going on around us, regardless of the pandemic, if you don't go to the emergency room because you're afraid, that may mean a life of disability. Every second counts when it comes to stroke. Every second that you're away from treatment, either with clot busting medicine or endovascular treatment, might mean a tremendous amount of disability, or sometimes loss of life. I've seen patients come to the emergency room and having mild symptoms, but declining the workup and leaving against medical advice, and then coming several hours later fairly debilitated and eventually passing away. And so, don't take stroke lightly. If you have any concerns, go straight to the emergency room, and folks will triage you appropriately, especially when you go to a comprehensive stroke center like the Samaritan Hospital Medical Center. Comprehensive stroke center certified by the Joint Commission means that there are protocols in place when you show up with a stroke. There's very little human thinking, which is a good thing when it comes to stroke. There are times when we think, but there's times where we really need to move fast and mechanically do things, and that's what happens when you're in a comprehensive stroke center. Things move fast so that you get your imaging studies the decision is made on the clot busting medicine, and then eventually a decision is made on endovascular treatment or disposition to the appropriate stroke unit, and eventually rehabilitation, because, you know, that's also very important. Like Mark mentioned, you know, rehabilitation really is another significant component of recovery. And as I said, what we do is very small, but the front end matters, the back end matters. That's why stroke is such a complex disease, because you have from one spectrum, from outside of the hospital to pre-hospital to out of the hospital. The whole spectrum needs to work perfectly. Otherwise, you're not going to have a good outcome. And as Renee, as you mentioned, pre-notification is key. You know, so we encourage our EMS providers to pre-notify. Now in Long Island, we have this privilege, obviously, to have a lot of volunteer EMS. And it's a privilege, but it's also a challenge, because if you're voluntary, you might not always be up to date on some things, because, you know, we need constant education. And so pre-notification is one of the most challenging things. So we're trying to encourage pre-notification, and you saying it through your show is obviously a significant component. Get the word out that obviously EMS needs to pre-notify the emergency room so that they're ready to go through their protocols. And it's one of the key metrics that's monitored by the Joint Commission, pre-notification through emergent medical services.
Yeah, I learned that because I was an ambassador for Valley Hospital in Ridgewood, New Jersey. Because that's where I had my stroke. So when I started my work, they reached out to me. A dear friend of mine, Michelle, who is going to be on the show today, she actually recommended that they talk to me about being an ambassador. And we sit, and this, Dr. Bekelis and Jason, you sit with every single dimension of stroke, like the EMS, the doctors, the nurses, every piece that is involved with the stroke. It's a once a month meeting. And that is what I picked up from it. Like, because I heard everybody talking, but and that's the important thing. The important thing is connection and letting people know, so that then you can cut down on the time, because like you said before, time is of the essence, And I know that it used to be 4.5 hours, but you had extended that. Although I don't want people to think that because they extended the window, you should wait longer. That's not why I'm asking. What I'm saying is you can extend the period of the clot busting or whatever if it calls, because sometimes people are by themselves. You don't know when they've had a stroke,
Correct.
I mean, and sometimes people can't get up. So what are you supposed to do?
Yeah, correct. And that's important, right? Mostly important for EMS, but also for other folks, that we used to say 3 to 4.5 hours, we have to give the clot busting medicine, the TPA. Now, because we have the ability to do mechanical thrombectomy, open the blood vessel through the groin, or because we have advanced imaging technology that can let us know whether the brain is viable or not, in select cases, we can even extend further out when we give the clot busting medicine. All in all, the window goes up to 24 hours now, especially for mechanical thrombectomy for the endovascular treatment. The window going to 24 hours doesn't mean take your time until the 24 hours. It just means that for the folks that, as you said, are incapacitated, they cannot talk, they cannot move, they're found by somebody, and that somebody doesn't know when the symptoms started. And so we're checking, we're saying, when was this person last seen normal? Where they were last seen normal 12 hours ago when they called their mom or whatever have you. And so that's the time of onset. So that's the 12-hour window. So now we can still treat that person if we get information from imaging studies that we can help them. And so that's key. Time is of the essence. Go to the hospital as quickly as possible. Now we have a longer window, which means we can treat more people, even the people that did not present on time in the past. But every second counts. So you showing up to the emergency room, say an hour after your symptom onset, is actually worse than showing up half an hour after your symptom onset or 5 minutes after your symptom onset. So the quicker you make it to the hospital, the better you'll do. Because, everybody's different, right? And we say this 24-hour window, but what really that means is that we can find some folks to help within 24 hours. There are some people that are going to get a stroke, and within 5 minutes, that part of the brain is going to be dead because of their vasculature, because of their anatomy, and there's nothing you can do to help them. And so that's important, that time does not necessarily mean that we all have the same privilege of time. Some of us might have, very good collateral circulation, which means that there's other roads that can get the blood where it needs to go. Some of us will not. And the ones that do not will develop a very bad stroke very quickly. And in these cases, there's not a lot of things you can do to help from an interventional perspective. But that's the key. If you go fast to the hospital, even if you are in the unfortunate group of not having a lot of collateral circulation, you might still have part of your brain that's alive. You might get treatment, and that might save your life. So time is important, but the message, I guess, that I'm sure you, throughout the day, you will give to your listeners and viewers is that the fastest you get to the hospital, the better your care is going to be. If you have the slightest suspicion of stroke, if it even remotely is in your mind, go straight to the emergency room.
Wow. Thank you. That's important. Empowerment. Jason, I'm going to ask you about your stroke recovery support center in 1 second. But Mark, you had your stroke on an airplane.
I did. And I had no idea what it was. Also, I thought a stroke was like having a cold. It would go away. Here I am 15 years later, still having after effects of a stroke. And Dr. Bekelis, I want to ask you a question. Let's go back in the days of yesteryear, when you were younger and you were deciding to go into medicine, there were different paths you could have gone down. Why this one?
So, it's a great question. I always wanted to be in medicine, but I love taking care of this pathology. I love taking care of stroke, cerebrovascular disease. The reason for it is that, and actually when I started being interested in it, we didn't have a lot of tools to treat this disease. These are recent tools that I'm describing, I would say within the last 5 years. TPA has been around for a very long time, but interventions for stroke, brain aneurysms, ischemic stroke, hemorrhagic stroke, like Judy mentioned before, like the spectrum of stroke is really a development of the last 5 to maybe 10 years that we're seeing. So when I was deciding to go into this field, it was because I saw that there's very few things being done, and I couldn't believe that we didn't have the ability to help these patients better. So the reason I'm in this field is because I love the pathology. I love to treat this particular pathology. And it's also a field where things are moving tremendously fast. Your decisions need to be quick. Your interventions need to be quick. And the reward is tremendous. You see somebody who comes to you not able to speak, not able to move one side of their body. They're tremendously debilitated. You put them on the table. You remove their clot without even giving them general anesthesia. And they're shaking your hand with a hand that wasn't moving a second ago, or they start talking to you. There's no way to describe the feeling when that happens. And so we often say, it's 2 a.m, we're all grumpy going to the hospital. But then when that happens, it's worth its weight in gold. So it's really a phenomenal field. And knowing what I know today, I probably wouldn't be in medicine if it wasn't for taking care of stroke patients.
I have one more question. My father said when he was younger, when people had a stroke, he would see them on the front porch just waving. Now, you see me, you see all these people who have suffered a stroke. There are people who see us, have no idea we've had one. You briefly talked on that, what has changed from then to now?
Mark, you're touching upon maybe the most important issue when it comes to stroke, right? We used to say when people come with a stroke, and that's not a long time ago, as you said, we used to say you put them in the back of the hospital, in one of the units of the hospital, and you just let them be there. Eventually they go to rehabilitation. There was no sense of urgency, right? We would go for the heart attacks, we would go for other stuff, but stroke was one of those kind of secondary, tertiary diseases that did not deserve a lot of attention. What's changed is that now we have the tools to treat this disease very, very, very effectively. I was looking at a statistic recently where I was looking at all interventions, there's a statistic called the numbers needed to treat, which shows you how effective an intervention is. And so, we know that, for example, if you're having a heart attack, you need to get an aspirin as a pre-hospital measure. And that intervention, you need to apply it to 40-something people to get one good outcome. When it comes to stroke, now our newest interventions, mechanical thrombectomy, for example, you need to treat only 3 people to achieve complete resolution of symptoms in 1, which is a tremendous number. Think of that. You need to treat 40 people with aspirin to get one good outcome, whereas you need to treat only 3 people to get one good outcome with this mechanical thrombectomy. So we really have powerful tools these days that are much better than any other field, frankly. And also we have systems of care where we can integrate all these multiple components when it comes to stroke. Stroke was challenging. People needed to know about it. EMS needed to know about it. The ER needed to know about it. You needed to have the tools to treat. You needed to have the right rehabilitation and in-hospital care. So we did not have all these components, but I think really what changed everything was now our ability to go in through the groin and open those blood vessels. And adding that key component then incentivized all the other aspects to really, start growing. And now we have the comprehensive stroke centers that really can change somebody's life. But you're absolutely right. It used to be stroke was an anathema. You're like, they're having a stroke, it's fine. Now these days, we can really make a difference. And I can tell you in my own institution because again, it's a culture thing. You change the culture of a place. So when I came to Long Island 3 years ago, in the South Shore of Long Island, there was no comprehensive stroke center. So, you're having a stroke, you were out of luck. That's only 3 years ago. And, when we came, we changed the culture of the hospital to the point where now identifying a stroke is probably, people are going to think stroke before they think a heart attack. They're going to think stroke in my hospital before they think seizure. They think stroke first. And that really has changed how patients are doing. And we're very proud of that. I can tell you, we're very proud. And that's why we have all our survivors. And Jason's going to talk a little bit about that. But, you see more and more survivors of strokes like you guys versus the other way around, the debilitated folks that are sitting on the porch and, they're just there and they're not.
Yeah. Thank you, Mark, for asking those incredible questions. Thank you, Dr. Bekelis, for your incredible answers. Jason, let's touch on the, the after. It's really, I know what it feels like. We know what it feels like to be a patient and to need the support of love and just camaraderie with those others that have had strokes, so that you don't feel like you're by yourself. So I know that you do that every day and you touch on that. So talk to us a little bit about that.
So when we talk about stroke care, a lot of times your hospital stay is a finite amount of time. Your rehab is a finite amount of time. And then what do? You go home and how do we continue the treatment, the support that you need? And one of the things at the Stroke and Brain Aneurysm Center here that we are very passionate about is our support group. And one thing that is important, as Dr. Beck was mentioned, when we came here, there were no services for strokes. We are open to everyone. We're open to all patients and, more importantly, family members. Family members can come without patients. Sometimes patients are very hesitant to come to a support group, especially males. We find out men don't want to admit they have a common cold, so they don't want to admit they have a hard time, or depression can be a big factor after a stroke. And family members are left with these questions. When will my loved one get back to normal? Is there a new normal? What can we do to help? So we find that the support group is very vital to the community and to people continuing to recover.
Yeah, we spoke about this last time. I believe you guys were on our show. We really think that family members are really the key to supporting because we know that as stroke patients, we're going through it and we're in it. We don't really know what's going on. But I remember my father sitting at the edge of my bed. I vividly remember. And I remember him having this look on his face, like, what is going to happen? What is going to happen? And I told both of you that really one of my foundation's vision is to create a support team for immediate action when someone suffers a stroke, that you call, you reach out, we form a committee and you reach out to us and we come in and we say, look at us. We suffered strokes, but look where we are. Trust. Just go through the process, show them love, and we support those family members to help them with the recovery, because they are an important piece of that recovery. Mm-hmm. They have to know how to navigate around that as well, right? They have to know that sometimes you have to push a little bit. You can't do everything for them, but sometimes you can't do too much. So there's a balancing act where you have to learn that, and that comes, I believe that comes, and this is where you guys would come in, that comes after everything settles down, right? Don't you think? Like, that comes after, like, the medical stuff, everything's found out, your brain gets a little bit defragmented, because you can't do any of that until you've gone through all that stuff. So another key to that is time. You have to just trust, love, have time. And, that brings us back to how life is so fragile, right, Jason? Life is so fragile. It could change in one split second at any specific time. And all of a sudden you're caught in this, what happened, So it really is, you guys are doing wonderful work. I was going to schedule to come up by you guys before this pandemic.
Yeah, yes.
But you're doing virtuals, right?
So we're back to in person at the hospital. Oh. But yes, for about 3-4 months during the pandemic, when everything was shut down, we thought it was very important to still offer that support, especially during that time, especially to these vulnerable people that that couldn't leave the house, were afraid to leave the house, and are considered more high risk because of their comorbidities. So we figured out that Zoom, that was one thing that came positive from the pandemic. I think Dr. Beckers would agree. Even with educating EMS, we found that sometimes to get everybody into a house, especially when they're off at night, they want to be with their families or something like that. We can set up these Zoom meetings now with EMS or with support groups and offer it to people who come into their home and make it more accessible. So sometimes you have to look at the positives that come from a negative situation. But I think moving forward, we know that this is a tool that works. We can use it, and it's made a difference.
Wow. Yes. So we have to close because, of course, we have to continue. We have 8 hours left to go.
It's a long day.
But it's such a joy. Anyway, we really want to thank both of you. Anybody else want to say anything to Dr. Bekelis or Jason before we go?
Keep up the good work.
Thank you. I also want to say thank you. I'm so happy that I was able to connect with both of you, because we didn't have anything on Long Island. And I heard about an aphasia center in New Jersey, and I didn't hear about anything on Long Island. So I did my research, and I came up with the best.
We did. Judy did her work.
Thank you.
Judy used to be, what did you used to do in your life, Judy,
Well, I started out in public relations and sales promotion, and then when my company moved out of town, I went to an agency and they said, "You're not going anywhere. You're staying here." And they gave me a desk and told me to do office staffing, and then they moved me to manager, and then I spent over 20 years as an executive recruiter for accounting and financial people. So I'm used to finding
how to find the best.
I'm used to finding
the best.
So Judy, thank you, and thank you all you guys for everything you do, and I hope you have a very successful day today, and we'll be here to support you in your efforts.
Thank you so much.
Thank you.
Thank you so much.
And just a quick
Hang on,
word.
Dr. Bekelis. Could you just hang on 1 second?
Sure.
And Jason, because what happens is we have to wait for a video to go on before you close. It just keeps the Jim in the studio has a better transition period.
Okay.
So just wait 2 seconds till you hear the music, and then bye to everybody. Thank you so much, Jason and Dr. Bekelis,
Yes.
for joining us today.
Thank
Jim?
you. And if anybody wants to know more about our support group that we offer, we're open to everyone, please visit Stroke Care Long Island. You can learn more about our center and about these diseases and treatments that we offer. So please feel free to reach out.
Thank you.
Thank you.
Jason.
Thank you so much.
Thank you so much. Jim, you could take it away.
One more time, let's go. I believe in music. Lord knows that I believe in love. I believe in music. Lord knows that I believe in love. God bless everybody. Have a stroke and rock, and I'll see you next week. I believe in love. I believe in music. Lord knows that